Today we have Eminol. He's the CEO of Explant Lab, and I'm not going to steal his thunder, but they've got just a killer service that every orthopedic patient in the world deals with is uh, alloy. What do you call it? Inflammation or reactions, and he's got a genomics test that solves the problem. But he's got multiple products, multiple tests, and he's got multiple sales channels he's thinking about before he comes to the U.S. So I'm gonna just hand the mic over to Eminol and be quiet.
Thank you. Let me just share my screen. Can everyone see that okay?
Yes.
Thank you. Let me just go full screen on the presentation. Okay, there we go. So, thank you for the time today, Tiger. I think the idea came from a previous conversation where we talked about anyone who wanted to get feedback on a pitch deck or business or what have you could put it up and get the shared brain power of the BoneChat group to get feedback. So we are probably about 6 months away from launch of our first asset into the US, and I was chatting to Tiger about potential sales channels and approaches, and he very kindly suggested that we share this on the call and get some feedback and brainstorm ideas on what might be a good approach for a startup of our size to really have an impact in the US. So I've got about 12-ish slides to run through, some of which are very quick. If there are any questions, please just jump in as we go. Tiger, could I ask you to just keep an eye out for raised hands? I can't see everyone.
Yeah, I'll be the moderator.
I'll take questions as we go if we need to kind of clarify stuff as we go through, but hopefully it'll be a shortish presentation and then a longer discussion. So, sorry, just aligning this slide. So when we kind of started down this path, we saw that most product development is generally being driven by manufacturers and focused on engineering-based solutions. So I think we counted 4,200 different knees, that have been available to surgeons over the past 15 years globally. A lot of focus on surgical technique, alignment, robotics, all sorts of innovation in materials, implant design, etc. And, more recently in kind of 3D printing solutions, but very little in terms of kind of patient factors and host responses. And this is where our organization has focused. So we have a vision that all patients will have access to fast and affordable pre and post surgical testing, just to ensure that they are genetically compatible with the implanted materials that are chosen for them. We know that implant surgery is not universally successful. There are, patients with unresolved pain, joint issues post-op, and depending on the sources you look at, anywhere from 10 to 15 to 20%. So anything up to kind of 20% of patients can have, complications, issues. I mean, I'm talking, longer term stuff here, not, within a couple of months of surgery, but, as things settle and patients get back to normality. This is from, the UK has a great tracking system, and this is data from there, and just shows reasons for revision. So this doesn't include patients that come back and, are managed for pain, long term with different solutions, but this is what drives revisions. And what we've seen is that metal hypersensitivity is generally under-recognized, but is a cause of poor clinical outcomes. We know that aseptic loosening and component wear frequently coexist with metal hypersensitivity, and we know that metal hypersensitivity is often misdiagnosed as infection. What many of you may not be aware of is that about 15% of patients actually carry genes that increase their risk of poorer clinical outcomes with cobalt chrome, and between 1% and 4% of patients carry a similar risk to implants containing titanium. So there's a genetic link between performance of patient interaction with the materials that are used for an implant. Over the past, kind of, I guess, 10 years of research, we've developed and now patented a genetic test that can predict the likelihood of an immune response in pre-surgical settings and identify active immune responses in post-surgical settings. So this is the only test of its kind, diagnostic test. It combines genetic data with age and sex factors to accurately identify patients who've got elevated risk. And in a post-op setting, we also measure metal ions, and the combination of metal ions and genetics enables us to identify ARMD in that setting. So that's a very kind of quick overview of the product. Our initial research, about 650 patients, was published in Nature Communications. So we were delighted, obviously, to get accepted into Nature, pretty prestigious journal, and pretty impactful research. Our follow-on study to this, Arthrogenics, it's called, will have twice these number of patients. Our first study was focused on cobalt chrome. The current study is focused on performance with titanium and zirconium. We should have that research finished probably by October and have the subsequent genetic tests for titanium early 2026. So I'm going to take just a short pause there and just ask if there are any questions on that kind of quick background before I get into the next session.
Yep, Elizabeth. Oh. Whoa.
You're on mute, Elizabeth.
You're on mute, sorry.
Yeah.
It's Chrome Cobalt? And I'm sorry, Elizabeth, go ahead.
Okay, that's okay. Yeah, I'm wondering, do we know what percentage of people are misdiagnosed as having an infection?
It depends on the papers you look at. I think the last one I saw was from there's about 44% of patients that came back had active alval, and a large proportion of those had initially been worked up for infection.
That's fascinating. I mean, I know this is not the time to dig into it, but I'm just wondering, what is the sort of thought process for the surgeon who thinks it's an infection?
They present very similarly. So it's a T lymphocyte driven response, which causes inflammation, tenderness, pain. So actually the presenting symptomology is very, very similar to an infection. So it's not a surprise that, aspirations would occur and they go down that route to check for infection.
Okay, thank you.
Mark, you have a question? Sorry, Mark, did you have a question as well?
Oh, yeah. So your initial study was on Chrome Cobalt
Cobalt chrome, yeah.
and Cobalt Chrome, and then the secondary study is on titanium and what else?
Zirconium.
Zirconium. Okay, thanks.
So another question?
That's it.
Go ahead. Eric?
Yeah, I was just thinking is that you think about the treatment, though, if they come in and they've got an infection, so a simple washout or antibiotic spacers, and they still have the issue with sensitivity to the material, nothing's going to come of it, right? So even if they now explant everything, wash them out, stabilize them, they put back in the exact same materials, they're going to have the same exact issue again. Yes?
So if the issue is alval and not an infection, then infection treatment will make no difference at all. The patient will still be sensitized. Even if they clean out all the gunk that's in there, the response will just continue to occur because at that point the patient is sensitized to whatever metal is present. Okay. So we have 4 products that we've developed. We have a preoperative test that quantifies a patient's genetic risk of a poorer clinical outcome due to developing metal sensitivity. We've got a DTC version of that same test preoperatively. We then have a post-op test, and this is where we combine both the genetic sequencing with blood draw to check for metal ion debris. And that is used to identify patients who've got a hypersensitivity response or an ARMD response with an implant kind of already in situ. And then the latest product that we've just developed and just registered with the MHRA in the UK is a test called Friction. and that identifies wear and loosening of implants with a titanium component. So they're the 4 tests that we have, and we have available in the UK currently. So obviously the US is a very attractive marketplace, and just looking at it by the numbers, and these are obviously kind of rounded, but around 800,000 knee implants, 450 hip implants, 100,000 shoulder implants, 6,000 ankle and wrist. I think that's about 5,000 ankle, about 1,000 wrist, if I remember the breakdown. About 300,000 spinal fusions done, and about 5 million dental implants done every year in the US. So that gives around 6.5 million pre-op screening opportunities, about 500,000 post-op screening opportunities. And with our pricing, that gives a total market opportunity of around $7 billion. So the marketplace is enormous. If you just look at it kind of, by the numbers, the available, the number of surgeries, if you like, with the pricing of the products.
Kyle,
Yeah, so Imanol, the majority in the US, probably 60% of trauma implants are now titanium. Historically, everything was stainless, and it's probably lagging around the world and still stainless, but most trauma implants in the US, whether it's plate screws, IM nails, those are titanium. You're going to want to throw those into your total addressable market as well.
Thank you. I will look into that.
great point.
Appreciate it. One of our biggest challenges, the total aside, is at the minute all this stuff has to be kind of sent off and genetically sequenced. We'd love to find a partner that can create an LFD that can identify the alleles that we're talking about, so you can move it to bedside as well for for urgent trauma. But that'll be a little bit down the ways for on the product development side of things. But that's certainly an interesting opportunity for future as well. Appreciate the comment, Carl. Thank you.
So rough math. Did I do my math right just now that you like $1,000 per screen? Is that?
It won't take less for the pre-screen, more for the more in-depth.
Yeah, I was just adding it all together on the fly.
Give or take, you're about right. And
Okay.
we have to do some pricing sensitivity work around this, obviously, but as kind of a start with some of the conversations we've had, it's kind of ballpark.
Okay.
Alyssa,
So I'm actually really familiar with the data that you present that I came in late on. And spine fusions are a big target, should be a big target. I think Celeste over at HSS co-wrote a paper that showed 40% infection rates. And now don't quote me on that. I heard this through the grapevine. However, they have they also, what was interesting about the study is the infection changed over time. And that's something a lot of people don't know in industry in particular.
Wow.
The second thing is your spine fusion numbers should be above 400,000. There's over 400,000 performed in the US.
Thank you. That was the last data I found. I appreciate that.
And that was 2014 was when it was categorized. So it's probably more than that now, but the data hasn't come out for 2024.
Thank you.
But I think you're going to have a big trouble, a big problem. Have you thought about commercializing direct to the consumer for $100?
That's just not possible.
Okay.
It's 4 to 6 digit resolution genetic sequencing. So that's just
I think that's the tough part is people. I think that's where you're going to have a challenge unless you get true reimbursement.
yeah. So can I just ask you to hold that thought? I'm going to come on to the business model, and I'd love to get all the feedback when we get to that section, if that's okay.
Of course.
Brilliant. Thanks, Alyssa. I share this not to go through it in any depth, but just so you guys have got a feeling for when when we kind of first started commercially, some of the milestones we've hit, some of the kind of usage we're getting. So we are being used by HSS in New York. We have one of the surgeons there who's both an investor and a research partner. We're starting to get therapeutic use under therapeutic exemption in Australia. Some surgeons there are very interested in the product. And we're getting used now in Southampton Trust in the UK, and just beginning a collaboration with BoneChat. So we're working with those guys in the UK, and we were in Germany to meet with their research leadership team a couple of weeks ago. We've been invited to present at the British Knee Society this year, and we've just had an invite to a panel discussion at AAOS next year. So that one is still in progress. So it's not kind of fully nailed down, but it's we want to see who else is on the panel before we fully commit to attending that discussion. But just gives you an idea of some of the kind of the recent traction that we're getting. So this kind of gives you an idea of the kind of big picture, what we're thinking about in terms of the value prop. Identifying patients at risk of poor clinical outcomes, identifying patients with ARMD, and we've had some feedback from a number of customers, should I say, potential customers that have said they thought the test was really useful in terms of mitigation of legal exposure if patients were screened prior to implant selection, because then there's been some kind of investigative work done prior to the implant selection. So if something does go wrong, there's some level of protection there. So we thought that was really interesting. It's not a particularly positive message to sell from, so it needs some work to think about how it's positioned. But it was interesting feedback nonetheless. So target customers, orthopedic surgeons, hospitals, and manufacturers, and then obviously patients through a DTC approach who are considering joint replacement. Influencers, surgical societies, KOLs, malpractice lawyers, if we do decide to kind of inform people around the legal side of things, and then obviously insurers, patient advocates, and the various online communities that they turn up in. In terms of potential revenue streams, there's the direct sales to providers and hospitals, DTC sales, direct to consumer, and then licensing to or partnerships with OEMs, and potentially outcome data, depending on the volume of data that's gathered and the agreements in place with that. Economics and scale, premium justified by the any kind of cost avoidance and improved outcomes. Consumer direct pay, great to get FSA, HSA eligible, and then really looking heavily into the health economics to get reimbursement. We are looking to have a central partner for pathology testing, DTC distribution, and then for future investments, we're very much going to need to invest in sales and marketing, as you'd imagine, as well as future product development. Some of the opportunities like dental will require an extension to the current research just to make sure that everything kind of holds tight in the dental market. So expansion into spine, dental, other implants, and then partnerships, kind of briefly mentioned, work with OEMs like we are with BoneChat, looking at big pathology organizations for testing and co-marketing, and then really trying to get validation through academic centers, hospitals, as well as potentially advisory alliances.
Patrick's got a hand up. Yeah.
Patrick.
Yeah, sorry if you mentioned this already. The test itself, though, is it a saliva test? Is it a blood test? Like what actually happens?
Yeah, good question. I should have made that clearer. Thank you. So the pre-op test can be done with a cheek swab or a saliva test. However, if you're testing post-op, it needs to be a blood draw because we need to be able to measure.
Yeah, that's different. I'm thinking the pre-op.
Yeah, so the pre-op can be done through saliva. With our initial test, with our initial research, should I say, in the UK, all of the patient DNA samples were done through a saliva test, and I think we were like 99% in terms of usable samples. So it seems to be a pretty accurate approach.
So nurse takes the swab in the office, they go off to a lab?
Not even that. It can be done at home with a saliva sample into a tube as well. So either or.
It's like a 23andMe, and it takes how many days does it take to get the results?
It'll depend on the partner that we use. But yeah, that results should be available comfortably within a few days for the pre-op test.
Okay.
Other questions?
So is this where we're going to stop?
I'm very quickly just going to share another couple of slides just to see if it prompts some So pre-launch, obviously getting the FDA filing. We're just ready to submit our pre-submission. We met with the FDA, had a couple of conversations. They are surprisingly interested. We had our first conversation with them, and they'd already appointed a principal investigator, and they had about 15 people on the call, including 3 immunologists and one of the FDA folks that we've done some previous research with. So they came at us kind of pretty hot out the gates with interest in terms of this. So next call is to then define, whether our initial submission is on target for what they're looking for. We're separating the pre and post-op submissions. Pre-op, we think we've got a strong predicate for 510K. Post-op, there's nothing else quite like this, so that would be de novo. So we decided to separate the two and go 510K for the pre-op to start with, so we can get something to market as soon as possible. We need to get the lab partner in place. Needs to be a lab that can do both next-gen sequencing and ICP-MS for blood metal ions. And we would obviously prefer a partner that's got full national coverage, and ideally one that's got inbound marketing capabilities. The big guys have got pretty good outreach themselves at this point. The lab needs validating, and then obviously, reimbursement is going to be huge. If we manage to get reimbursement, then that'd be a total game changer in terms of product adoption. So that's the big CSF for us in terms of full adoption. Initially want to focus on getting some early adopters, build up some steam in the US and kind of expand from there. I think they're probably the key points on the pre-op side of things. And then post-op, our plan is to, or should I say our goal is to get the kind of pre-op approach as a standard of care for implant selection. So we have a pretty good idea of who we'd like as our pathology partners. And we've got a pretty good feeling for what we think the value prop will be, who the target market, target customers are. Our big challenge is the sales partnership side of things. We're a small organization, UK based, and so we need to find the right kind of channel approach from a pure sales perspective, like some of the influencer stuff and testing stuff. Hopefully we've got our arms around. Inbound marketing, should be reasonably straightforward, but the actual direct selling piece is what's currently kind of keeping me up at night. So this is where I was hoping to get feedback from the good folks on this call, in terms of what the ideal sales model could look like, what sales partner options could look like, 1099 versus W2 options, national versus targeted coverage in the first instances, all these kind of types of questions.
Kyle, you're first.
So this is probably not the sort of thing that displaces someone's current income, right? They're not going to be all of a sudden have this huge windfall, make a ton of money. So you're looking for borrowed sales force.
Yep.
What would you say is the perfect sales partner by the type of products they already carry, the type of territory that they're in, the type of patients that those doctors treat? Like if you're mapping out whose bag this fits in the best, do you have that thought through?
If I did, I wouldn't be having this conversation with the folks on the call, Kyle. So I don't know the US market hugely well. So that's what I'm trying to kind of pick my way through is, who the ideal sales partner is. Clearly a partner that understands this space and, the metal hypersensitivity space is useful. But there aren't so many of those, big players. I think there's only Smith and Nephew really in the US now that Aesculap have withdrawn from the US. So that's I think being in the bag with those guys would be a tough ask. We actually had a contract with Smith and Nephew in place for about 18 months, and they were awful to work with. So I actually closed that contract down about 6 to 8 months ago.
Patrick?
Who owns the company? Like, who are your, not necessarily by firm, but like, how are you funded? Because who your investors are matters a lot in terms of pace. A lot of times it's the investors that want the companies to go faster than they really should if they want to get it right. So
So
who's
we've got to where we are just through angel investing. So about $2.1 million of angel funding over the last 3 or 4 years. So we're majority owned by the founders and a small handful of angel investors.
okay, so that's good because I think you could probably screw some things up by trying to go too fast,
Yeah.
too quickly in a rush to sort of just like sell as many units as you can as fast as you can. There, so I'll let others. I'm going to have a million other questions, but I'll let others go.
Wheels are turning. Go ahead, Mark.
One of the reasons why I invited Carl is that he is CEO of a product, an adipose-derived stem cell product that is cash-based. So there's no reimbursement.
Yep.
And I'm going to invite him to relate a little bit, but I'll let him do that on his own time. There is 4%, there's 4% of all orthopedic surgeons now operate on a cash-only basis. And many of them focus on total joint replacements. And as I'm sitting here thinking about that, I'm wondering what a great niche that could be. Because one of the things that they might be interested in doing is taking a high value test like this for a high value patient client and maybe bundling that with other high value extras as sort of a package or bundle. Anyway, the wheels are turning. This is interesting. This is a
Mark,
very
Mark, that's a really interesting thought in the US. I'd not even considered that. You know, we are looking at health tourism markets. And in the health tourism markets, you know, where you have wealthy individuals who are going to travel to get a joint replaced,
Yeah.
we think it becomes exactly that. It becomes part of the bundle of, hey, you know, we're the hospital that genetically tests you before you have your joint done, and it becomes part of the kind of the value prop to a high value patient. But I hadn't made the connection and thought of that in the US. So thank you.
A concierge service for wealthy people.
Yeah, 4% are cash only, another like 5% are concierge. And that's another probably kind of similar or analogous market. Anyway, I'm like Patrick, I got a lot of other questions, but I'm gonna shut up.
All right, Karen's up next, and then Alyssa.
Yeah, not the expert here, but just a couple of comments. I'm based in the US, actually working for a European company, so I empathize a little bit. But we're in the digital health space. But I'm concerned about a few things. One is I would slow down. That's the first thing. I think to come to the US without reimbursement is a recipe for, in my opinion anyway, is a recipe for suicide. I would stay in Europe. I would get your clinical data, get your business model actually embedded in the NHS, in the, maybe continental Europe or whatever. And meanwhile, in parallel, get your either, I'm not sure if FDA comes into this. I'm not sure if I saw that, but oh, you mentioned the FDA. Yeah, sorry. But also the reimbursement can be a very long and winding road. And I think if it doesn't fall under an existing code, going for a new code is very, very tricky. And I think coming over here and focused on Mark knows the market way better than me, but focused on concierge tourism is not going to satisfy investors, or it could be a massive distraction for you. So I'm urging caution. I'm not a scientist. I don't know the efficacy of the product, but I have experience selling European solutions in the US market. We don't need reimbursements as it happens, but I've done it before with a different diagnostic, and it's a tricky area. So
Thank you.
Well, good comments. Alyssa?
I would definitely echo that. I have been on the sales side. I've been in the clinic side. I've also been in the executive side. And I've been in thousands of cases. Of the total joints, the thousands of cases and just specific to total joints, there was probably one really bad infection a year. So I don't think that the market, the general market is your market, particularly if you don't have reimbursement. And also those surgeons will not postpone their cases. I think at the complex institutions like HSS, where they get a ton of infections, they get the worst of the worst cases. They already, when they get there, they already know that those patients are infected. And they already know what their issues are. However, I do see a value in like foot and ankle because there's like Charcot, a lot of diabetic patients in that population. I also think that you have a research opportunity that could be huge, comparing the before and afters to products like GLP-1, because GLP-1s calm the inflammation. I'm wondering if you could do a before and after surgery and to help propel sales for the GLP-1s, using it as a sales tool in partnerships with pharma companies.
So I just wanted to clarify that the product's not for infection.
It's a DNA sequencing, if I'm correct, that's preoperatively done, and it takes 30 days to get the data back to say that this patient is likely to have an infection issue.
No, it's not an infection issue. Sorry, it's a metal sensitivity. It's an ARMD issue.
Okay, so metal sensitive, but you had 4 different products.
Yeah, it's metal sensitivity. It's Alval or ARMD
on there, and each of the products had their own specialty. Okay, like metal sensitivity, that's not going to be a mass seller.
We're losing
Be an
your
opportunity. Oh, I'm sorry, I'm driving.
You're kind of going in and out, but let's go to Carl and then Patrick's up next.
So everybody's kind of piling on this this reimbursement thing, and yes, I'm eyeballs deep in getting a new code, and that. So you're talking about when we get reimbursement, is there a pathway? Like have you mapped out a pathway to reimbursement? And then just a secondary question, so I was in corporate spine for with J&J and Stryker for quite a while, and for the metal testing for the sensitivity, there were some and they're rudimentary, they're not anything like what you're talking about, but where we'd just put it on the doctors would put it on the skin if there was a concern,
Just tape it to the arm, or
Yeah.
so I don't know, I know that's riding a bicycle and you've got a Ferrari, but how do you have you looked at that, and what
That's actually one of the biggest challenges is that the testing that's out there at the moment is crap. Skin patch testing doesn't work. Melissa testing is 50-50, so you get lots of false positives, false negatives. So one of the big reasons that metal hypersensitivity is not actually taken more seriously is that there's never actually been tests with any degree of accuracy that actually give results that are valuable or actionable. So there's definitely a kind of a work of education to be done to kind of show what the issue is, and can't say too much because we haven't published the data yet, but we now have clear outcome data showing the difference in outcomes in patients who have cobalt chrome joints and who carry the at-risk genes, and those that don't. So we're getting to the point now where we have much better data, but there's undoubtedly an education job to do here, because the previous tests have been pretty poor to say the least. And to answer your first question, we're just now starting on the health economic work for reimbursement, and I didn't put that sentence down as if it was a slam dunk, having worked in the pharma industry for 25 years. That's a huge mountain for us to climb, and will be the difference between a modestly successful approach and a much more successful approach if we do manage to get reimbursement. So big hill to climb, undoubtedly.
Well, the 510K is here does not mean anything as far as reimbursement. So
fully aware of that. Yeah.
Yeah. So but there's also as far as the DNA testing, there's some, I wouldn't call them predicate device, but that's what's on my brain. But there are some, have been some tests out there that, that they've been able to bill for, but, so as you look into that, but
Yeah.
that's it. It's a big hurdle.
Patrick?
Another just like basic question. Who presumably is actually buying this? Like who's writing a check? The doctor's offices or the healthcare system if the physicians are employed? That matters a lot in terms of like who you hire and who your sales personnel, who they're used to calling on, what types of sales they're used to making, things like that. Who's actually buying the product? And are they buying, presumably they're buying in bulk, they're buying boxes at a time, right? They're buying hundreds or so at a time, I would assume, right?
Yeah, so in the UK, we sell it in kind of bundles of 10 boxes, 10 tests directly into the hospital for use with, in the office, doctor's office with the patient, surgeon directly to the patient. So that's the approach that we're using in the UK. We originally went through the pathology labs. Our partner in the UK is NHSBT, so it's actually an NHS testing lab. But the NHS is just such a car crash to try and work with that we actually found it was more difficult trying to work with hospital pathology labs to get the test on the path lab, a system to get it used, and it was far easier to get it ordered just through the surgical suite if we provided the boxes ourselves. So that seems to have been a better way of approaching the market in the UK.
Yeah. This is probably obvious, but regardless of if your sales force is 1099 or W-2 or some sort of mix, the ease in which they can sell into private practices, because this is an office test, will be so much higher, so much easier and faster than if the physician is employed by the hospital and everything runs through the hospital's purchasing department.
Yeah.
Even in these private groups that have gotten a lot bigger, they're still orders of magnitude smaller in terms of like their overall sort of purchasing spend, and smaller is better in this case. Smaller means faster and easier. I wouldn't even try for a while to even bother trying to sell into hospital systems unless you had a surgeon who was really willing to go to bat for you and willing to expend a lot of sort of political capital within their institution, because to walk into a big hospital system and ask them to start purchasing in-office tests based on one doctor sort of liking the product when there's no reimbursement. I mean, that's a big hill to climb, rather than, I think it's a lot easier to convince a couple doctors, within a practice that they should adopt this for their,
Yeah, thank you.
use that. Then they will be thinking in terms of like part of the sell, I think here is competitive, like that. Once somebody does it, the guys across the street don't want to be the ones who are not doing it. They look sort of irresponsible if they're not doing it.
Yeah.
And a big difference. I've worked for European companies for many years, so you may know this, but like I tend to resort back to like one of the fundamental differences between orthopedics or medical devices here versus Europe is that here the doctors have to compete against each other for patients in a way that they just sort of don't in Europe. A mentor of mine, I hope no one takes offense to this, but a mentor of mine called most European doctors like a highly prestigious municipal employees, almost, that they sort of just show up, they're doing their work, and then they're going home. But here they're running independent businesses, they're competing against each other. They think of the guys across the street as like the people who are trying to sort of take food off their table. So I do think that there's a competitive dynamic that in any individual city, or even on a smaller level, places where there's like two main orthopedic groups in a city or in a state or something like that, and especially if they're private, that will help quite a bit.
That makes sense. Thank you.
So Alyssa put a comment in, the nickel wrist disc doesn't work well, but it's free and it checks a box off for defensive medicine. It's also rarely used, and pricing is going to be the key. So I think the thing we don't know is that, I mean, people don't want to admit that they don't know there's a alloy reaction ahead of time or even after. Nobody wants to know. And now for the first time ever, we can know. I think that's a big challenge, is maybe education. Go ahead. Mark's up.
Does anybody on the call have a law degree? The reason I ask is that it seems to me if you have a published paper that says 15% of your patients are going to have a reaction, whether a scale of 1 to 10, whether it's a 1 or a 10, and that becomes well known, that becomes part of the standard of knowledge, then that would proceed for some sort of standard of care to have a better testing system than we do now.
Yeah,
If you
sure.
do not have that, it seems like you may incur some sort of liability as a practitioner. We all know that there are tests being done every day that are, quote, unnecessary or may be deemed unnecessary, especially if they're negative. And yet they're done routinely because of the perception of liability or the perception of additional risk if you don't do them. And this could easily fall into that category. 15% is a huge number. What's the cost of that? Who bears that risk now? Who would care? I guarantee there's a bunch of attorneys that once they learn about this, may be interested in learning more.
Yeah, we have had some interest. So our founder, it does some work, some medical legal advisory work in the kind of space with failed joints. And yeah, a couple of the practices that he works with, especially in the US, have asked questions about the testing and when it'll be available. So I think it's a very small cohort. We're talking about a couple of practices that we speak with, but there does seem to be some initial interest, Mark.
Can we
Yeah, I mean,
hammer? Can I dig down on that 15% number that you've been mentioning a
Yeah,
couple of times?
yeah.
So if 15% of patients, stop me when I'll
Yeah.
eventually say something incorrect. So just stop me when I do. 15% of patients have a cobalt chromium sensitivity.
Yeah, 15% of patients carry the gene
Uh-huh.
that predisposes them to a sensitivity reaction.
But then like what percent of that 15% does it actually matter in? Because there's no way that 15, if 1 million knees get replaced, there's no way that 150,000 of them are coming out because of metal sensitivity every year.
No, and metal sensitivity is the reaction is kind of grading on a scale.
Uh-huh.
So it's linked to concentration, and we have pretty clearly established thresholds now above which point it becomes an issue. So if you imagine it as a kind of a 4-box grid, you've got concentration of metal ions along one axis, and the level of risk due to the genetic predisposition on the other axis. If you carry the genes, but you have a perfectly performing joint, say you're kind of bottom left,
Yeah, right.
then you're fine. However, let's say you have a mildly elevated level. You're not going to be symptomatic at a very mild level, but if you've already got metal debris, that's only going to increase over time. So in that instance, the patient should be tested every 6 to 12 months to make sure the concentration of metal ions isn't increasing, because once it hits that threshold, the patient is going to develop ARMD. So it depends on the performance of the joint and the level of metal debris. So it's a measure of risk. It's not saying that kind of 15% of all patients. It's saying 15% of all patients are predisposed to the risk, depending on the performance of the joint that is in situ.
So do you have a sense then numerically of like that 15 gets whittled down to what in terms of like some percentage that it actually should matter?
So in why have I forgotten?
And by matter, I shouldn't clarify. Like by matter, I mean like kind of qualitatively things that like would cause a patient to show back up into a doctor's office for a doctor to think there's a failure, those types of things. Not just like I'm at home doing okay, but 5% worse than I might have otherwise been.
Yeah, so the paper by Lombardi, and 44% of patients that they measured in their cohort that came back with pain, 44% of them had active ARMD.
Okay.
So
yeah, I mean, I would get going on as powerful of an economic study as you can. To Mark's point, You could see dots getting connected where people start thinking it's almost irresponsible, and you want to almost product position that it's like that it's almost irresponsible to not do uh, um, something like this, and don't underestimate the fear of especially um, I'm stereotyping here, of course, but Europeans tend to underestimate the the fear of legal action, especially amongst in the medical system amongst U.S. surgeons, and you can't lead with brochures, talking about hey, you can sort of never it's like a huge unspoken thing kind of all the time that you don't brag and you don't put it on a trade show booth, but it does play a big relevance into how people think. I would also just be aware though, like your numbers, like have them, they need to be so sort of tight and irrefutable. You're about to like step into major shark infested waters here, that there is a multi-billion-dollar industry of people who sell cobalt chrome. And if you're going to come along with a test that tells them that 15% of those patients that they're selling cobalt chrome to, and by selling, I mean not just the companies, but I mean all of the doctors that are running basically assembly line surgical factories in their office and in the hospitals, and to like come in and interject yourself and say, actually 15% of these people are predisposed to metal sensitivity. You thought it was 1%, but it's actually 15%. That's going to be very disruptive, and their instinct is going to be to find reasons to say you're wrong for blah 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 blah, these types of reasons, even if they're only process reasons, that they think that having to add another
If
test
people are sensitive, it's just on the spectrum of sensitivity.
Yes, right,
And so,
exactly.
I mean, it's really commonly known. And they'll ask it, have you ever worn a wristwatch and showed sensitivity? People, for the most part, know if they're sensitive. And but the thing is, it's on a spectrum, and that's why they do the patch test. There's blood tests. I can tell you, out of the thousands of total knees and shoulders and trauma and sports medicine, foot and ankle, there's probably been less than 20 that have actually needed to be all the implants taken out and then re-put back in. Spine, there's a much larger percentage.
My question is, how do you know
that's
that?
because the screws, I think it's because the screws get reprocessed over and over and over in the machines, because they're titanium screws traditionally.
Yes,
so
I think
I agree 100% that the numbers have to be viable. And I believe that you have an opportunity here to capture a market, but you're in an uphill climb because surgeons are not going to postpone their cases for this test, because the rarity and the severity of it is low when it comes to pulling it out. I do think at the teaching institution levels and the research levels, there's a big opportunity for research, but metal sensitivity, while it's known, it's again on the spectrum.
I think it's very poorly understood, and it's interesting what you say about how many cases, and because I would argue the challenge is nobody knows how many cases there are, because the only way previously to test is through histology, and people aren't taking metal ion levels and they aren't doing histology to test for alval. So we've had the conversation numerous times with folks who've said to us, that no, I don't think it exists. I've only ever seen one or two gross reactions. And then when you get into it, you find there's no screening, there's no accurate testing, and they actually don't know what they don't know. So I don't disagree with the outcome, which is the same thing, which is it's going to be an uphill battle, because it's not well recognized. But I think folks who say they've never seen it don't necessarily know that to be true, because they know
it to be true. Yeah, anything with nickel in it, they know it to be true. I don't think you're going to have a problem.
We're not talking about nickel. There's a huge confusion, and a type 1 mediated skin response to nickel is very different to a type 4 mediated cobalt chrome response that's T lymphocyte driven. So I think that's one of the challenges. It's misunderstood that you do a skin test for a type 1 mediated dermatology reaction. That does not correlate at all.
I completely agree. But if you're looking at the revision rate, if you're looking at the overall revision rate on the market, and you have a 96% success rate in total hips across the globe, it's going to be an uphill climb, is what I'm trying to say. And we can tennis match this all day, but I'm trying to do you a favor, because I think you have a really good product, but I don't think it's going to match the market at the opportunity that you have pitched.
No, I think that's the size of the market. So the opportunity that we're actually able to access, is obviously going to be markedly smaller than that. That's the total number of actual, if you like, opportunities that would be there for usage. But I don't for one second believe we're going to become a $7 billion organization. And I appreciate the input, Liz. I truly do. I think it is a very challenging market for us to enter into because there are entrenched ideas, entrenched practices, and there are folks that will not want this to be true. So I appreciate everything you're saying.
But I think patients will buy this on their own, and that's typically the market that they're buying it at. They're buying the blood sensitivity tests, and people are very curious about their own health. And yeah, it may not pay the bills, but it at least brings in data, initial money too, revenues for the company, and then it guides you which direction to go, and it shows it could be a phenomenal opportunity for patients.
Yeah. I got very similar advice from very two wise individuals called Tiger and Mark about 2 months ago. They agree with you 100% that a direct-to-patient could be a very interesting start to kind of gain a foothold while we're expanding. So yeah, appreciate the insights.
Kyle and then Patrick.
Yeah, I don't disagree with what Alyssa was pointing out, but one counterpoint would be that even these gigantic companies that sell, a couple 100,000 knees a year are still pursuing titanium bearings and ceramic bearings, all under the expectation that there is some level of demand somewhere about metal sensitivity, whether it's, how quantifiable the reality is or not is arguable for sure, but there's something there. But one of her main points that I think is really, really important for you is you're going to struggle to be disruptive to an existing business model. So perhaps from the front end, you need to focus your efforts on where does your business, your product align with the business model that maybe isn't so near term. So you might want to be thinking about players that are more in the patient specific space where there is a time delay, and it's a perfect opportunity to inject something diagnostic in the front end because there is a time delay anyway.
Restored, companies like that.
That is one I had written down.
Yeah, interesting. It would just be an extra $500 charge.
I mean, they're going to build something special anyway. They might as well know if they're going to build it out of X or Y material based on a test result.
That's a really good point.
A really good point, yeah.
And so as far as keep an eye on 3D systems and 3D side as well that are playing in this space that are more of the suppliers, but are trying to get into more of the production and ownership element of it.
Thank you.
What about allergy specialists? They test, this could be fantastic. Completely outside of orthopedics. Maybe orthopedics is not your market. Maybe it's the allergy specialist market. They're the ones that will prescribe this. And the physicians actually send the patient to the allergy specialist if they assume that there's a likelihood that they have an allergy to an implant.
That's a great point. Thank you. I'm writing that down. Yeah, so it's not something I've looked at, to be perfectly honest. We've been so focused because all our research is in orthopedics that we've had the blinkers on in that respect, for sure.
Because I have a unique perspective because I worked in the office for years as a tech. And so I understand that pathway. I think that's your market. Does anybody think that would be easier? That would be an easier pathway?
The allergist
that fits into an existing system, right?
Yeah. You're not recreating something. And the allergy specialists, patients, even if they're not getting implants in, the allergy specialists are going to test. They test for all sorts of things on the skin, but now you're creating a market that already has a pathway and already has reimbursement in place.
Somebody that's scheduled for a knee operation, usually they don't go see an allergist.
No. If the patient comes into the clinic, and every patient gets asked the question, have you had issues with your earrings or your watch or anything like that? Any kind of skin issues? And if they do, they automatically get sent, typically, at least my surgeons did, they would send them to an allergy specialist to make sure that there wasn't a high rate of it. Especially people that answered that question definitively yes, they would go automatically to allergy specialists. However, there are patients that are constantly have inflammation, and they seek an allergy specialist on their own. And it might be due to an implant in their body. It might be due to wearing an implant. They don't know where those sensitivities lies. So they test for like hundreds of different allergies sometimes.
Yeah. Really interesting point.
Yeah.
Yeah, there could be patients who've got, like you say, going along for an allergy testing, they've got, gross inflammation or universal inflammation, and maybe they've had a hip replacement or a knee replacement, and this could be an additive test if they're getting multiple panels done. So that'd be interesting to speak to a couple of allergists and dig into that one for sure.
I have a really good one in St. Louis, and he's very much so on the regenerative side. He's doing all sorts of GLP-1s and so on and so forth. I will be happy to connect you. He's very curious, and he likes pioneering things.
That would be really appreciated. Thank you.
Excellent.
And instead of doing 1 or 2 a week, you might have 20 a week per physician.
Patrick?
I think getting some like real easy to regurgitate, thinking of like how salespeople would deliver types of messages, something on, I think there needs to be more fleshed out, and maybe you just know it and it wasn't conducive to a presentation in this format, but on this, people who, because Alyssa's right on this, like in terms of a spectrum, like it is like the metal sensitivity is a spectrum, but like if you baked into all of these sort of like product positioning assumptions is that like people are doing worse than they otherwise would because they're walking around with knees that they have some degree of metal sensitivity, and they're doing worse than they otherwise would if they had, I guess, known about it and gotten an implant made out of different materials put in. But like that's just like, I don't think you'll get too much pushback that like you're saying that's incorrect, but like figuring out how to like tie it together in a I hate the word narrative, but that's the first word coming to mind, of like getting the story around that, of like why it's impactful to community doctor XYZ in their location. I think that's really important, because if and just to try to answer these questions that you have up here, like I would not put this in the hands of 1099 people right away. I think there's way too many unknowns that you guys as a company need to better understand. The 1099s, they're gonna like the distributors, and I assume you mean like third-party distributors, not that they're good at like a real specific thing, but I don't know that this is it. And it's they're much more sort of physics guys on average. They're more physics guys than chemistry guys, and they're used to like stuff in the OR, and, especially the bigger networks. There are not all of them, but in general, it's much, especially talking to orthopedic surgeons, they're much more, angles and momentum and friction and loads and those types of things, rather than chemistry stuff that they can't see with their own eyes. So I would be a little nervous to like just say like let's tap into as many independent distributors as we can, at least from the get-go. I don't think I would hire somebody and put them in the right geography and tell them like, we just, no matter good, bad, or whatever, we want you to report back everything you're finding out, right? And give them freedom to say people don't like this, or I'm screwing up, or whatever the case is. But to just like say like let's just go color, like get in a big map coloring exercise, I don't think would be advantageous right away for something like this.
Yeah, thank you.
I kind of pushed back on that a little bit, and the reason why is because I saw so many distributors profiteer massively off of compounding of drugs and prescriptions, and so they totally sold outside of their lane However, there was a huge financial benefit there that I don't think can possibly exist with this one. They
Good
won't,
point.
but I think you definitely have something.
You're right about
Thank you.
it was the money.
I was gonna say that one was all cash.
Yeah.
That was motivator, and if you'll look at the DNA testing, and Mark, you may have been involved with the DNA testing because that was a flash in the pan too. That insurers paid for DNA testing one time, and it would tell what drugs you were allergic to. Same kind of thing, but just for the drugs. And I don't know a ton about that because I was doing different things, but that was hot for for a short minute too, and then that was only paid for once, but it was those 1099s and independent networks that went out there and were hustling because it was such a big profit margin. Mark, were you involved in that or the?
I looked at it just kind of like I looked at compounding, and the rate of return was so extremely high that it just kind of made me feel like I just want to bet, or I was going to wind up on a talk show or maybe on an exclusion list for fraud. I just stayed away from it.
No.
Something like that was just seemed too good to be true.
It's like stem cells, stem cell injections. Yeah.
No, I wouldn't say that.
Yeah, no, platelet-rich plasma and bone marrow are awesome, actually.
great.
There's
They're great.
great data. Yeah,
Yeah,
great
you don't
data.
sell one bone marrow aspirate and make 25 grand.
That's true.
That was
Yeah.
just the enormous profit that just made me stay away from it.
I was the exact same way,
But
Mark.
a manual, if you'll do some research into the DNA testing, that was, as I said, it was probably a 2014, 2015-ish
Yeah.
flash in the
Yeah,
pan.
so we are under NDA with 3 major path labs. So we've been making good progress there, and I'm hoping to be able to get some conversations with their folks that focus on the reimbursement and the coding. And so we know, for example, that metal ion testing for titanium and cobalt chrome does have a code. So there is a code exists there. So what I don't know is if that code is something that can also be used when you start adding in the genetic testing to go with it post-op. Is that going to be a totally new code? Obviously, a new code will change potentially what the reimbursement level looks like. So hoping that the folks who do this for a living at one of the path labs can, at least point us in the right direction, because they do the genetic testing and the metal ion testing on a daily basis, and they do have codes. We've come across some of them online. Now, how easy it was for them to get those codes is a totally different question, but I'm hoping they can, give us some better insights.
Well, your approval is going to have, everything to do with if those codes are applicable. Because if you don't have the right indication with your approval, those codes, don't mean anything to you.
Yep.
So, getting the right person to run that strategy, or making sure you pursue it out of the gate is huge.
Thank you.
So I know we're kind of bumping up on time, but what would be a really cool, fun project, Eminol, would be to do a big survey and get some big influencer, several hundred a year, total joint gurus, ask them their thoughts, educate them on the numbers and your research and the European experience, tell them it's non-reimbursable, ask them how many patients they think would pay, and then take that same survey to the allergist, for example, to see what their thoughts would be, to take it to somebody who's used to cash pay, the quasi concierge or the cash pay docs, that 2 or 3 research projects might wind up saving you a lot of time and money.
The allergist piece and the concierge piece, I agree with you 100%.
Yeah.
The surgeon piece makes me really nervous. I mean, last year there was the big meeting in Istanbul that came up with a position paper and basically published that skin patch testing for nickel was the gold standard. So if that's what the experts are getting together and saying at a big meeting, it makes me nervous that without being able to do the relevant education, we're just, throwing noise into an echo chamber.
I wouldn't
So
honestly, I wouldn't super worry about that. I mean, there's major retrospective studies that show only a 2% revision rate in spine. And like I have surgeons that say to their patients, there's pretty much 100% likelihood after about 15 to 20 years, you're going to have another level fused. And so like, you know, that's the thing about research. There's an opinion for everything. But I think you being aligned with HSS and getting some grants to get some money in and do the actual research and understand, have 2 different market pathways or 3 different market pathways will really dial you in very well in what, you know, 2-3 years from now looks like.
yeah.
Great advice.
Well, look, I've got you know, several pages of notes here, and I think kind of thematically hearing that, you know, kind of the DTC approach, you know, could be a good initial approach to get some usage and some experience in the US, but that kind of coming to surgeons prior to having clear reimbursement with reimbursement codes is something to be considered with real caution, because if we don't have that, then, you know, getting the uptake is going to be challenging. And then taking a bunch of notes around messaging around, you know, the liability side of things, the positioning of kind of patients doing worse than they otherwise could have in terms of, you know, the pain scores, etc. So a lot here for me to digest and think about. So I hugely appreciate the brain trust that's kind of given the feedback today. Thank you so much.
Yeah, I could see everybody's wheels turning, you know. When Eminol and I first met, you know, I told him right off the bat, I think the big total joint manufacturers don't want to know.
Mhm.
They're gonna fight this so
Yeah.
hard, and they're gonna tell their KOLs to fight it.
Yes, that's why I said you're swimming in shark-infested waters. There's billions of dollars of industry that doesn't want your numbers. They want those buried.
Yeah.
That's why it's an education play, and when you go direct to consumer, you can do an end run around the whole, you know, sales channel.
Yeah, I thought that my first thought was let's get this guy on Joe Rogan or some big podcast and set that, you know, conspiracy mill going.
Yeah.
They've been keeping this test away from you for years.
It would be nice though. It would be a great marketing campaign. I mean, look what they've done with MIS and female knees and or gender specific knees and robotics. It would be a nice campaign for a company to go, we actually care.
When
Yeah.
the natural one, the natural Smith and Nephew, because they have the
Yes.
non-cobalt chrome, non-titanium
Yeah.
stuff, you know. But
Oxenium, yeah.
those
Yeah,
guys, they're idiots, though.
Well, if they could use it to upsell the patient too, that's the other angle.
I mean, the original conversation with Smith and Nephew was they wanted this as a companion diagnostic. They were struggling to identify patients, and they were struggling to get approval for more expensive implants without something that said the patient actually needed it. And we had some very interesting early conversations. And then, as always happens, you know, the product manager for Oxenium left, went elsewhere, and then wasn't replaced for 6 months, and you lose momentum. And then a new CEO comes in who's focused on robots, and yeah.
Was that with people just in the UK though, or was that with people here?
No, that was with people here. It was the guy
Okay.
in Memphis who was
Okay.
who was the global product manager. So it was a real shame that it lost momentum.
Yeah, they could be the big winner if they played it right, but they don't understand it.
Okay.
Yeah.
Robots are sexy. All right. Well, this has been great. Thanks for everybody's extra time.
Thanks, everyone. Appreciate it.
Any follow-ups you want to have, Eminol? You know, why don't you tell everybody? Do you guys want his email address?
Sure.
Just put it in the chat, because I know there's going to be offline. I know there's going to be offline discussions.
I
Yeah.
sent you a LinkedIn request, Eminol.
Great. Thank you. Appreciate it, Alyssa.
Happy to help. I apologize if I came across a little brash.
No, not at all. The challenge is important because, you know, everyone thinks their own baby's pretty, right, till someone else looks at it. So.
Alyssa is a very nice person.
Well, I firmly believe if it's not the initial path, there's got to be a way. And so that's the thing of business. There's always a way.
Well, we're speaking at BASC next week, and we're sharing the data from our unpublished data from our arthrogenic study. It will be fascinating to be in a room full of the top knee surgeons in the UK
Wow.
and getting a real life response from them. That's where we'll get a real feel for, okay, is this data actually hitting? Are they making sense of it? Do they get it? Will it change practice? So pretty excited about, getting live feedback from those guys, because that'll tell us how hard the climb is.
Tiger, I'm going to close with the best sales advice I saw this week. And I cut it out in the newspaper. It said, just stop talking. I love that.
That was last week's sales discussion was awesome. There were so many pearls of wisdom in there. And one of them was good salespeople don't talk, they just listen. Yeah. All right. Thanks, guys. That was great.
Thanks, everyone. Really appreciate it.
Now, what picture of your wife was it, Mark?
No, it was. It could have been though. I've heard that. Thanks a million. Thanks, Carl.
Bye.
Carl.